And Megan, I don't see the deck anymore. Did you close? Oh, there it is.
I had to close it in order to record.
Oh, okay, got it. Good.
All right, so this is our third installment of GRI University, and today we're going to be talking about GRI treatments and cures. And I'm going to hand it over to Keith to talk a little bit about our sponsor today, Homology Medicines.
Yeah, so first, before we do that, one thing that we've done over the last couple of weeks is we have asked everybody who's on the call about sort of their knowledge of science. And I think both weeks we've had people ranging anywhere from early high school to some people that have done post-secondary education in biology, not just the researchers. So a wide range of knowledge, certainly. But I want to ask a different question today, because today's session focuses on the search for treatments and cures for GRI disorders. And so I want to start, so use the chat and type in your answer there, but don't click submit yet. Okay, so the question is, write down a year when you think that there'll be a cure for at least some GRI disorders. And if you don't think that'll happen, you can write never, but otherwise, write a year in the chat. Give everybody a chance to do that. If the researchers are brave enough, they can do it too. Okay, people are starting to press enter, so you can press enter now. So I see 2025, 2028, 2026, 2032, 2025, 2030, 2030, 2028, 2030, 2024. Well, these answers include, I can see some of the researchers that have answers there. So this is pretty encouraging that everybody on this call thinks that by the end of this decade, there'll be some kind of cure for at least some GRI disorders. And I think, there's lots of debate about what that means, whether it'll be maybe only for people with gain of function variants or loss of function variants, and whether it might be something that initially only helps newborns with GRI disorder. So there's lots ahead of us and lots to learn, but I said 2030. I feel like we're in a really good place right now, where there's a lot of research going on into gene therapies in general, and especially for starting to figure out how to use genetic therapies for neurodevelopmental diseases, but also at a time where there's a lot of interest in medicating the GRI receptors. And in the past, that people have been looking at that for all kinds of related disorders like pain and depression and other things. But there's an interest right now from biotechs on actually looking at treating GRI disorders specifically, treating these receptors specifically for people with GRI disorders. So yeah, so it's a really exciting time. And one of those companies that I talked about is our sponsor for these sessions. So that's Homology Medicines. Really grateful that they're sponsoring GRI University. They've also been a company who's been working and collaborating with CureGRIN and with researchers in the space. And they are partnering with Dr. Amy Ramsey and Dr. Graham Collingridge at the University of Toronto to on some gene therapy trials that are just beginning now. So there's lots of excitement going on. So thanks to Homology. Thanks to all of you for being here. I have to go give a presentation in another meeting, so I'm not able to watch this session live. So I'm going to catch up on it later. But thanks all of you for coming, and have a good session and a good weekend.
Thank you, Keith.
Thanks, Keith. All right. So just to reiterate what our goals for GRI University are, so we understand that GRI families have different backgrounds and experiences, and we really want to empower our families to learn more about GRI disorder to give you the tools to be able to gain more information from our conferences and from other discussions that take place on GRI Connect or in other meetings with families and researchers. So really, we want to give you the tool set to make that happen and to allow you to gain more skills. So in our first session of GRI University, we talked about genetics and how it relates to GRI disorders. Our families learned a little bit about prevalence, symptoms, treatments, life expectancies, etc. And this session was put on by Ariske Liston and Dr. Johannes Limke. And you can actually watch the replay on CureGRIN's YouTube channel. It's already available. And then in our second session, we talked a little bit about loss of function and gain of function and why that's important and how functional characterization of variants works. So we heard from Dr. Ian Coombs and Dr. Jeffrey Swanson for this session. And we also learned a little bit about neuroscience and how it relates to GRI disorders and all of the different receptors that comprise the GRI disorders. And you can also watch the replay of that session on CureGRIN's YouTube channel, since that one is also out now. And today we are going to be focusing on if a cure is really possible, and even if what that might look like for older children or even for adults. And so this session is going to provide an overview of the options for gene therapy and pharmaceuticals and what that might look like in terms of retreatments. And we will discuss a little bit about CureGRIN's research roadmap. So an overview of the session, we're about halfway through that. So that's going to take about 10 minutes. And we're going to talk about existing treatments and drug development. We're going to hear from Dr. Tim Benke. So he has a recorded video that we're going to share with you guys. Then we're going to hear from Dr. Krey, who's going to talk about drugs that target receptors. And Dr. Ramsey is going to talk to us about gene therapy. So first, we wanted to ask, what is gene therapy versus pharmaceuticals? So gene therapy is basically a technique that's used to introduce genetic material that's basically intended to fix variants or genes or to make a protein and to make that protein functional. And so there are many different forms of how that may look, and we're exploring different options. Some of the candidates include things like knockdown and replace, which is basically where we are knocking down the bad copy and replacing more with a good copy. And so Dr. Ramsey will go a lot more into what gene therapy looks like. But just to give you some definitions of how we're comparing these two things. So gene therapy, again, is a technique that's using genetic material, whereas the US Food and Drug Administration describes drugs as substances that are intended for diagnostics, cures, mitigation, treatment, and prevention of disease. And then there are things called new molecules. So those are those that haven't been approved yet. They're called new chemical entities or new molecular entities. And so when CureGRIN is talking about things like drugs, we're describing medicines that have been previously approved for either another disease or another condition, but can still be helpful for GRIN and GRI disorder. However, when we're talking about molecules, we're talking about describing new potential medicines that haven't yet been approved by the FDA. And these include things like agonists, antagonists, PAMs, and NAMs. It can also include repurposing drugs that have been used for other indications. And there have been many N-of-1 trials that have been done in GRI patients for different medicines. And there's currently an ongoing clinical trial focusing on L-serine. And we're going to hear about that more a little bit later. And then just to define what we at CureGRIN consider a treatment versus a cure. So a cure is a medical intervention that would reduce the disease or the range of symptoms by rebalancing the receptor that's affected. So for GRIN, that's going to be the Nmda receptor. For GRIA, AMPA. For GRIC, that's going to be kainate. And delta, any variants that would be related to GRID genes. And so this would be through things like gene therapy or pharmacological treatments that target the receptor specifically. And when we're talking about a treatment, we are talking about a medical intervention that could help one or more related symptoms by targeting the receptor or by targeting specific symptoms such as epilepsy. I see Dr. Ramsey raise her hand.
Yes, Megan, are you the host?
Oh, yes, I am.
Can you please mute everyone, because there's someone who there's a lot of background noise and it's really hard for us to hear. So can you make sure everyone is muted?
Okay. It may be me with background noise. I am in a cafe. Can you hear it now? Is that better?
It's Sue Banks and I can't mute her. I think she's away from her computer.
Is that better? Can I get a thumbs up from someone? Oh, Dr. Ramsey, thumbs up. Is that good? Okay. All right. Sounds good. And so what we would define as a treatment, again, is something that would affect one or more related symptom, or by targeting receptors or specific symptoms such as epilepsy, for example. And when we asked families, and when we asked families about balancing treatments and cures, our families said that if they had to choose, they would choose that there's a slight edge over treatments over cures, and presumably that's related to the time that it may take to develop a cure. But if you take a look at our graph here, about everybody, over half, wanted us to pursue them equally. And then for treating symptoms, 29%, and finding a cure alone would be 16% from our family survey that we did with over 200 participants. So that's kind of the landscape of what the community is looking for. So they want us to prioritize both finding long-term cures and short-term treatments for symptoms. And so at CureGRIN, we're pursuing a 3-tiered approach to address this. So we are trying to put about 40% of our time and effort and funds into gene therapy. And then we're putting about 30% of our time, effort, and funds into targets of the receptors. So that would be the Nmda receptors, AMPA receptors, kainate receptors, and delta receptors. It just says Nmda receptors there, but it's an old slide from our roadmap. But anyways, that would entail things like agonists, antagonists, PAMs, NAMs, and more so of a cure treatment combo that are targeting the receptor specifically. And then drugs that are targeting symptoms, which would be like epilepsy drugs, drugs to target downstream symptoms, GI issues, things like that. That's about 30% of our time and effort. Okay. And without further ado, I will try to share Tim's video now. 1 second. Let's see. One moment.
Megan, there's quite a bit of noise where you are. Is there a way for you to share the video and mute your surrounding?
Yes. Okay. Yes, can do.
Okay. So we can't hear Tim, unfortunately. I guess you're going to have to, yeah. Okay. So, Megan, I think that what you need to do is change your output so that, you know what I mean? If you go down to your microphone, you want to make sure it's.
I think your volume is all the way down as well.
Let's try this. Did that work? No. 1 second. Denise, if you also want to pull it up and see if you can try too. Is that working? No. Okay.
Megan, I'm in a pretty quiet place. If there's a way you can send it to me, I can share it.
Okay, I will send to you now. If let's see, Dr. Krey, if you want to go ahead and start presenting, I'll try to we'll try to fix this and then we can play it a little bit later.
Yes, sure. So I try to share my screen.
Okay, 1 second. I'm gonna go ahead.
Yeah, you have to. So does this work?
It looks good.
We can see your screen. Perfect. So hello everyone. My name is Ilona Krey. I am medical doctor at the Leipzig Institute of Human Genetics, and I'm very happy to talk to you today. Our topic will be existing treatments, drugs that target the glutamate receptor, which are namely the NMDA, AMPA, and kainate receptor. We are here in the third part of the GRI University, and I won't repeat the function and biology of the glutamate receptors that we heard from Dr. Ian Coops 2 weeks ago. So the focus today will be the drugs interacting as agonists or antagonists on the receptor. Therefore, it is important to understand how these receptors work in general. Let's start with the NMDA receptor encoded by the GRIN genes and a short genetic background on disease-associated variants in the GRIN genes. Generally, there are two types of genetic variants, missense and null variants. Missense variants can either lead to an increase of NMDA receptor function, which is called gain of function, or they can result in a reduced NMDA receptor function, which is called loss of function. The second type of variants, the null variants, result in a complete destruction of the respective gene copy and a mechanism called haploid insufficiency. Oh, this was too fast. Such haploid insufficiency does usually not alter the function of the ion channel itself, but can very well reduce the density of the NMDA receptor in the cell membrane. The NMDA receptor contains 4 subunits and requires co-agonists on every subunit for activation. Glutamate and glycine are both essential to induce the conformational change needed for the NMDA receptor to allow flow through the calcium. Additionally, other co-agonists such as L-serine can support the agonistic effect. This is important, especially in case of loss of function or null variants, where L-serine can counteract the reduced receptor function. So Sojo and colleagues published the first case in 2019 showing beneficial effects of L-serine treated in a child with GRIN2B loss of function. And in the beginning of this year, our group published a case series with 9 individuals with loss of function or null variants in GRIN2A and GRIN2B. And we showed that behavior improvement was reported in 8 of these 9 individuals. 4 of 9 individuals showed improvements in development and in EEG or seizure frequency. And none of these individuals experienced side effects. There is another ongoing clinical trial in Barcelona with 20 individuals with loss of function variants, and we are very excited for the upcoming results. In contrast to the agonistic effect of L-serine, memantine blocks the NMDA receptor. It had an antagonistic effect. And therefore it is an important mechanism in case of gain of function variants to reduce the receptor function. You can see here the structure of memantine, and it looks like in a oh, you can see it here. In the middle of the receptor, memantine blocks inside of the pore of the receptor. So memantine is an approved drug for Alzheimer's disease, and only few cases are reported in the literature regarding the use in GRIN disorders. So we plan to publish the same we did with Elserine. Right now we have approximately 20 individuals, but this is also a retrospective case series and not a real clinical trial. Another antagonist is radiprodiel. It modulates especially the subunit 2 encoded by GRIN2B. Radiprodiel was initially developed as a treatment for neuropathic pain. There are promising preclinical data of 3 individuals with infantile spasms treated with radiprodiel published by GRIN Therapeutics. So the next step will be a clinical trial starting hopefully this year. And other NMDA modulators are spermidine, dextrofan, and many others, but for now there are no existing clinical experience with these drugs in GRIN-related disorders. The second glutamate receptor is the AMPA receptor, encoded by the GRIA genes, GRIA 1, 2, 4. It is and perampanel is an AMPA negative allosteric modulator, or also called antagonist. It is a licensed anti-epileptic drug approved by the FDA for focal epilepsies. So compared to the GRIN genes, only marginal knowledge is published for treatment of the GRIA-related disorders. Recently, Dr. Coombs and colleagues showed beneficial effects of perampanel in an individual with a gain of function variance in GRIA2. And other antagonists and agonists are listed here, but as far as I know, there are no existing clinical experience due to GRIA-related disorders. Same for GRIC-related disorders. As far as I know, there's no ongoing clinical trial or case studies published of any known agonists or antagonists. The third glutamate receptor is the kainate receptor, encoded by the GRIC 1 to 5 genes. Glutamate and kainate acid could be a possible agonist, and the listed drug tezampanel might be a potential candidate for gain of function variants in the GRIC genes. So we do need to find out more about suitable drugs, and therefore we need clinical trial. This is the only way to find more information about the drugs or potential drugs in the glutamate receptors. So thank you very much for listening, and I think we do have time for questions.
Can I ask something about the GRIC receptors?
Yes, sure.
Because you said there's no studies or clinical trials going on, but then you show some agonists or antagonists, so it was too far. What makes you think that there could be a cure for that? Those could be cures for GRIC?
No. there are known agonists or antagonists published online, but no one knows if these could be a potential drug because no one tested them already.
Okay.
But they are the general mechanism, how they work as agonists or antagonists, this is known.
Okay, understood. Thank you.
So I sent the video to Amy as well. We'll try to see if we can get that pulled up. Sorry for the technical difficulties, everyone. Appreciate your patience.
And open it now, or are there more questions? Okay, I'll go ahead and share the screen.
Hello, GRI University. My name is Tim Benke. I am a pediatric neurologist at the University of Colorado and Children's Hospital, Colorado. I'm going to talk to you today about existing treatments and drug development. These are my disclosures. The important ones are here, that I'm involved with the functional and clinical evaluations of glutamate receptors, mutations in epileptic encephalopathy studies, sponsored by Simons, that lives at Emory, where Dr. Trainellis is the PI. I'm also scientific advisory for GRIN2B, GRIN Therapeutics, and CureGRIN. So we have a lot to talk about today. I'm going to talk about some existing treatments for epilepsy, spells and storms, sleep, GI, and therapies in general. I'm going to talk about N of 1 trials and some clinical trial basics. So it's a lot to cover. Seizures and spells. So here are some important key questions that you should try to review with your clinicians. You want to be able to describe the events from start to finish. On average, how long do they last, and what's been the maximum duration in the past? When did they start? Are they still occurring today? How often do they occur now, and what is the maximum frequency in the past? What happens afterwards, such as sleep? Does anything trigger these? Does anything help? And were they ever captured on an EEG or other physiologic recording or your cell phone? For spells, what are the possibilities? This is important because it helps define what the treatments are. The description plus diagnostics hopefully gives an answer to suggest therapy, and this is a clinical decision that you come to with your clinicians. It could be a seizure, movement disorder, sleep disorder, autonomic instability, a change in anatomy, behavioral, or sometimes you're just left with unknown. But ultimately, the treatment goals are no seizures, no spells, and no side effects. However, this may be a balance that you establish with your clinicians. What are some diagnostic tests to consider? Well, a cell phone video is great because it catches the event in its natural state. The cons are it's hard to do. You sometimes need a third arm. And there's, of course, limited physiology that's recorded as part of this. A video EEG, this is the ideal recording condition, but you have to be lucky enough to be hooked up at the time to capture one of these. Sleep study with a video, same sort of situation as an EEG. These are ideal recording conditions, but you also capture additional physiology. And the cons are also you just have to be lucky enough to have a spell and capture at the same time. An electrocardiogram or Holter monitor. These are ideal for capturing cardiac physiology. Also, same issue, you have to be lucky enough to capture them. Imaging, such as another brain MRI. These are useful if there's been an overall change in your child outside of the spells that's there and it's a new change. But otherwise, it's not really useful or needed if it's already done as part of an initial diagnosis and there's no other change other than spells. Seizure classifications. This is important that you work with your clinician to ensure that you're on the same page. So if you decide that there are 2 different spells and you all eventually decide that this is a seizure and that it was a tonic seizure, try to use the same terminology. If everyone's okay knowing that you're calling a whoopsie a specific seizure type, then that's okay. And spell B, everybody knows this is not a seizure. And of course, differentiating some seizure types is difficult, but the bottom goal is it's important to keep a drop diary of the different spell types to track what is working and what is not, and the side effects for each spell type. Standard therapy for each seizure type should be considered because specific seizure types often have specific therapies. And just to mention the registry, as part of that grant with Dr. Trainellis, it's, if possible, asking your clinician to help you fill out the forms may make things easier, or you can be sure to send us their notes if you're not sure. Seizures and spells. So a quick wrap up that the therapy always depends on what caused the spell, the nature, the physiology of the spells, the impact of the spells, the side effects of medications, and the safety and efficacy of approved medications. You'll notice I haven't talked a lot about neurostorms, but essentially each one in my experience is quite different. And so if it's not a seizure, then specific discussions with your clinician and trying to figure out what are the specific symptoms that you're trying to target is often the way to proceed. Safety. It's always important to ensure safety during a spell. And I refer to these as the 3 T's and a 4th T of seizure, but also spell first aid. Time it. 5 minutes for seizures is our cutoff. For spells, it's less clear, but we know that we don't want seizures to last longer than 5 minutes because that's the time when we usually like to give a rescue medicine. For seizures, it's important to be on your tummy or your side in order to protect the airway because a lot of times individuals will throw up with a seizure. Tongue, don't worry about it. Your child's not going to swallow their tongue. And if you feel that you're able to pull out a third arm and you're able to T-mobile or capture it on a cell phone video, that's often useful for your clinician. Sleep disorders. This is my approach to addressing the issue of not sleeping at night. The questions are really, is it a part of initiating sleep, maintaining sleep, or both? The other main issue is are there other things that are going on during sleep, such as snoring or excessive movements? Another important question is your child too sleepy during the day because they're not sleeping at night? And some folks are just ravers. They don't sleep at night. They often don't sleep for several nights in a row, and then they crash. And it's important to know if that's the situation as well. With regards to sleep, it's important to make some environmental adjustments as much as possible. Set the atmosphere, make sure that there's a safe space in the bed, and you have your routines down, and you go through the same routine every night. Think about, is there anything else that's part of sleep that is making things difficult, such as reflux or constipation? If nothing can be figured out with some of these types of measures, then I think of medication trials. If there's an issue with initiation, I think of melatonin or melatonin agonists. If there's difficulty with maintenance, melatonin is often not very helpful in that regard, but melatonin agonists, clonidine, gabapentin, or trazodone can be helpful. If there's other issues such as snoring, I think it's really important to work with a sleep specialist and consider a sleep study. GI issues. Just remember, this is all part of the autonomic nervous system, and glutamate receptors are needed here for function as well. Thinking about reflux and constipation is important because treatment improves nutrition, health, and especially quality of life. When it comes to reflux, some questions are, is your child irpy-burpy? Do they swallow air? Are they refusing food? Are they overeating? Are they not sleeping? These can all be signs, subtle signs of reflux if you're not overtly seeing it. One of the ways to address this is try to adjust the diet, and if this doesn't help, then consider a trial of medications. And taking most daily medications are okay. Constipation. The goal is 1 soft bowel movement every day. Try to adjust the diet, and then if this doesn't help to achieve this goal, then consider a trial of medications. And also, daily medications are okay, even for long periods, such as for a lifetime. And you don't want to keep doing a cycle of using the medicines and then backing off, and because otherwise there's too much fluctuation. Find what works with doing the same thing every day and try to stick to it. Feeding. Coughing, choking, spluttering, taking more than 30 minutes, or a flat weight curve. These are important signs to consider that proper nutrition is just not getting where you want it to. And it often feels like a failure to parents, but sometimes you need to consider a gastrostomy too. Nutrition. I think it's very important to work with a dietitian and make sure that the adequate nutrients are being obtained, and to consider a vitamin D supplement, especially if you're on anti-seizure medicines. Therapies, I think it's very important to consider physical therapy, occupational therapy, speech therapy, augmentative communication. With a lot of our patients, it's very important to do a vision assessment and make accommodations in the educational plan if needed. And often an individualized education plan needs to be formed. It's important to know your rights under the law with regards to these issues. And there is a very important and useful website, check out rightslaw.com. If you want to look at a comprehensive guide in another disorder that may be of use, and I think it can certainly be applicable to some of our patients with GRI disorders, please check this reference out here for Rett syndrome. So what are N of 1 trials? These are an individualized approach and outcomes for each person. So an outcome measure is what you're trying to target, and it depends on your preference. And what you're trying to figure out is what you're doing really working. Meaningful change. So it's important to decide ahead of time with regards to that outcome measure, what is going to be useful to you in terms of continuing with the therapy. But this meaningful change is subjective to each person's experience. And what works for you may not work for everyone else. In other words, how do you know if something improved for you, it was going to be really useful to everybody else in general? Prior safety for these medicines hasn't already been established, and safety measures can be arbitrary. And it's need to be thought well through ahead of time. What do you measure and how often to make sure things are safe? If there's an improvement or worsening, it's difficult to know, could this be the medication, or would this have happened anyway as part of the natural course of the disease without the medication? So when these N of 1 trials for GRI disorders, the choice of therapy depends on prior knowledge of the functional status of the specific change in your GRI receptor. Is it a gain of function or is it a loss of function? Because each of the N of 1 therapies is dependent upon knowing that. What we know so far for loss of function, using a medication called L-serine, it's been reported that in GRIN 2A and GRIN 2B, there's improvements in behavior, development, EEG, and seizures. And there's 2 papers that are out there in the literature. One is from Ilona Krey and her group, and reported the largest series of 10 patients, and 9 of those patients appeared to have some improvement, but one of them got worse, and it turned out that this individual had a gain of function change, which is why it's important, gain or loss of function. For gain of function changes, memantine, dextromethorphan, magnesium, and ketamine have been considered. For GRIN 1, GRIN 2B, and GRIN 2D, there's been improvements in medically refractory epilepsy and status epilepticus. And overall in the literature, that's a relatively few number of patients that have been reported, as I note here. 1 in the paper from Zhu et al., 4 in the paper from Platzer et al., 1 in the Pearson et al. Paper, another 1 in the Amador paper, and then 2 in the Lee et al. Paper. So the experience is largely somewhat limited. So in my opinion, these are helpful to understand safety and support going forward with standard clinical trials. I'll talk to you about what that is. But for these N of 1 trials, it's in my opinion that these should be only for extreme situations, such as ICU admissions, multi-daily seizures, or something else that's you and your clinician decide is very impactful. And there is a genuine discussion about the benefits and risks of trying something like this, because I think it's experimental. And it's important that the functional status is known. And if this comes up, your clinicians can also contact me at any time for recommendations about what I might try in any particular situation. So, clinical trials for GRI disorders, here we are. So this is where we want to be, treatment specific to GRI disorders. And how we have to get there is we need preclinical research and research through the clinical trial process. And it's important to remember that this is research and it's not treatment. even though there might be the possibility of some treatment-related benefits to your child. Basically, the goal is to have a successful trial, which leads to FDA approval, and then availability of treatment for all people. Ideally, that's how it's supposed to work. As a patient and family, it's important to ask questions, get informed, and please enroll in trials. And of course, be patient with the process because it is a process. So I think it's important to go over some clinical trial basics. So what is a clinical study? What is a clinical trial? So this is a process by which subjects and caregivers consent and assent to participate in a defined study designed to produce information that can be used to understand or help the population as a whole. This data is peer-reviewed and published to advance the knowledge and effective and safe treatments of the disease. Trials are interventions. Voluntary, you don't have to participate unless you want to, and you can withdraw at any time. A review board must approve the trial before any subjects are contacted and enrolled, and there are international rules and standards and ethics that are applied. Safety is always the most important thing. There are specific but broad assessments that are required during the trial. There are phases in clinical trial. Each phase is typically a separate clinical trial. Phase 1 is testing healthy volunteers in multiple doses. It may be in patients with advanced stages of a disease or disease with no known treatments. Safety is primary. Phase 2 is testing on patients for efficacy and safety. And phase 3 is a confirmatory trial testing on patients for efficacy, effectiveness, and long-term safety. Phase 4 is long-term safety assessments. And the FDA will typically approve for use after phase 3. And this may be different or exceptional, however, with gene therapy because this is very new territory. There are different types of clinical trials. There's a placebo-controlled trial where a placebo or sugar pill is used to make sure the effects are real. And it's important to note that patients with epilepsy can see a 25% reduction in seizures with the placebo. I've got another slide to show for you about this in a second. Randomized, that means who gets placebo or drug is a flip of a coin. Double blind means that the subjects and the local study personnel do not know who is getting drug. Open label means everyone's getting a drug. Crossover means those getting the drug then get the placebo and vice versa. It's usually randomized and double blind too. Extension. This is access to the drug after the trial ends, and it's usually an open label continuation of the trial. The gold standard is randomized double-blind placebo, but it's thought that this is not going to be true for gene therapy trials. So I wanted to talk a little bit about the placebo effect, and this is what was seen in a blinded Rett clinical trial. So Rett syndrome is a different genetic disorder, and basically individuals with Rett syndrome were treated double-blind in a randomized clinical trial. And so this is study day over here, and this is change from treatment baseline in a score that's specific to Rett syndrome called the RSBQ. So if you went down like this, your Rett syndrome symptoms actually improved. So the individuals who were getting placebo, they actually improved by a few points in this measure. However, it's important to note that those that got the drug did have a bigger improvement. And this was also seen in another measure called the CGI. So again, individuals who were getting drug had demonstrated improvement to both the clinicians as well as the parents on this particular measure. However, there was a bigger difference as the trial went on between the two groups. So that's why it's important to have this placebo control group, but also have a very structured trial that lasts for an extended period of time so you can really tease out if there's an improvement or not. So clinical trials, what to expect as a participant. We live by the protocol. So basically, you can't make any exceptions. You've got to go with what the protocol says. The first thing is the screening visit, where you make sure that you meet the inclusion or exclusion criteria of the trial. You sign a lot of paperwork, and there's often a lottery or industry approval of who gets to participate in the trial. The inclusion and exclusion criteria, these are usually things like age, weight, disease specifics, other medication use, recent trial experience, and there's no exceptions. The clinician at the site can't change these rules. They're already set in stone by the company. The duration, this is duration of treatment and follow-up during the trial, and study visits. These are specifically time for the trial to get good data. Like in the Rett trial, everybody got evaluated at specific time points. And so they're not that flexible, usually plus or minus a day, not weeks, and not optional. So it is an inconvenience to participate in a trial. You've got to change your life to fit the trial. The study coordinator is somebody who works with the families to try to fit it into their schedule. They happen over the duration of the trial. Try to make things as much family friendly as possible, but it's important to get good data. The endpoints and outcomes, these are the measurables to determine safety and efficacy. Clean data is the goal. It means you have to be very careful about meeting the exclusion criteria and inclusion criteria. And we want to make sure that when something's approved, that we can feel confident that what we're offering is safe and effective. And it's important, again, remember, this is research, it's not treatment. The medicine that's being trialed, it could help or not. It's very different from when if your clinician offers you something that's been approved. And then post-approval, this should be available to all. Good data. Another thing to remember is having the same caregiver present for visits ensures consistent data. This also brings in some issues with regards to travel if you have to travel for a trial. So being in a trial, just a visual. So there's a screening visit, and then there's a flip of a coin as to whether or not you're in a treatment group or a placebo group. That's the randomization. Then there's specific clinical trial visits. Then there's a final visit, and then the drug might continue after the trial. After that finish line, then that data gets taken and it's evaluated to determine if the drug is safe and efficacious. So clinical trials, what about the patient voice? So what types of trials are acceptable to this group? This is an important question. What types of symptoms should be treated? How are they assessed? What are meaningful symptom changes to a family? And how does the age of the individual impact these questions? So understanding the patient voice is something that we need to hear from you. And we, meaning especially the FDA, they often do something called patient-focused drug development meetings. And there have been some recent meetings for both Rett and CDKL5 disorder that I think it would be important for the community to take a look at. And here's some links to those there. And it's important to capture the outcomes correctly. And one of the ways that we're trying to do this, of course, is with the registry that we're doing here. And Johannes Lemke is doing for Europe. And then eventually, at some point, we would like to have even more clinical data to inform the natural history. So clinical trials, why does it take so long to get started? Well, of course, you need preclinical data first with looking at efficacy and safety in animals. This happens in academia and industry. And then there's outcome measure development and natural history. Second, there's solicitation of the patient voice. This often happens by industry. Then there's human protocol development, and the industry often does this. And then federal regulatory approval. Sometimes this takes 5 to 10 plus years. Then once a trial starts, there's site recruitment and approvals, there's contract and budget approvals, site ethics board approvals, then site initiation visits happen. Then enrollment finally begins, and we can call you and you can show up. And this is where we are. We're still in steps 1 and 2. Clinical trials, where do you get information? Well, one place, of course, is Facebook, but Facebook has contaminated trials in the past. So don't be that guy that ruins a trial for the rest of us by posting. Email, internet, blogs, me. I'm not going to endorse any particular trial, though I'll participate in some. But the important thing is to trust but verify. The only real sources are clinicaltrials.gov or sourced from there, and the company website, but also importantly, the consent form for when a study starts, and the study investigator can tell you after it's approved by their regulatory board. As mentioned, it's important to bring up the registry. If you haven't enrolled, why not? And this is the pathway to advanced functional analyses in order to determine if you gain or loss of function. And it's the pathway to discovering natural history. There's a new portal that's a one-stop shop for all. But if you're in Europe, Asia, or Africa, here's the link to Dr. Lemke's website. And then in North, South America, Australia, here's the link. If you can email Jennifer Sargent or Jennifer Bain, These are two different studies collecting different but very similar and important and complementary data. So we went through a lot. I think I probably went over time, but I thank you very much for your attention. And you can get in touch with me through CureGRIN. Thanks very much for your attention.
Thank you so much for sharing that, Dr. Benke, and Amy for sharing your screen. We greatly appreciate it. If you want to go ahead and start your part of the presentation now.
Sure, will do. All right. I'm gonna start here. Okay, everyone, thanks so much. I'm going to treat this like I would a university class, and I'm going to try and teach you a little bit about gene therapy for brain disorders. And the first thing that is important to point out is that there are already a lot of challenges for any kind of drug discovery for brain disorders. So we need, when we're looking for a drug to treat a disease that affects the brain, we need to make sure that the drug gets into the brain, because the brain is very good at keeping out poisons and bacteria and viruses. The body does a lot to protect the brain from everything that might hurt it. And so it can be challenging sometimes to find a drug that we can get into the brain and cross what's called the blood-brain barrier. We know how to do that, but it's just an extra challenge. And then once that drug gets into the brain, it will attach to receptors that are on specific cells. And when the drug attaches, it will change how that cell is working. And so this is the basis of how all drugs are working, is that the drug gets into the brain and binds to its receptor, and then will change the function of that cell. We need to have a way to measure whether the drug is working or not. And so in order to do that, we use cells, but ultimately we need to have animal models to test the drug and make sure that it's doing what we think it's going to do. And then, once we're very confident that it will work, we can think about clinical trials. And in the clinical trials, we have to make sure that the new drug we found is better than any other current treatment, if there is one. And we also verify that the drug does not have any toxic effects. The reason why I say all of this is that this is true whether you're talking about gene therapy or the typical drug that you would take, as a pill that we're all taking now for our headaches or our hypertension or whatever. And the tricky thing with drugs is that the dose is the most important thing, and timing is also an important consideration. Really, it's with timing, it's making sure that the drug stays in the body for a long time, so that it can last and have enduring effects. And I mention this because this is also true with gene therapy. So even though gene therapy is very new, the principles of the challenges that we need to do are true for anything. One moment, please. Okay. Sorry, I've got the family is is here. Okay. Let's see. There's a question in. Okay, great. Okay. Okay. So moving on. What is gene therapy? Gene therapy. These are medicines that are composed of DNA or RNA, and that's just a type of chemical, honestly. So DNA is the chemical that makes up the hereditary information that is stored and that we pass on to our children. And the RNA is the go-between between the DNA and the protein. So we can make medicines where we give people DNA or RNA to change the function of genes. So they're designed to either replace a missing gene that you might have. So some people will have a gene that is missing or deleted or not working at all. And we can add back and replace that gene, or we can prevent a non-functional gene from causing problems. So sometimes if a gene is not working correctly, it can cause problems, and the best way to fix that problem is just to quiet that non-functional gene. Many of you have probably heard somewhere in the news or in Facebook posts, where all of the patient advocates are getting together. You may have heard something called Crispr. And Crispr is an acronym for a big, long phrase that honestly doesn't matter. So what you need to know is that Crispr is an enzyme that can cut DNA, and it can repair DNA. It is a big improvement over anything else that we have discovered because it's really efficient. So every cell of our body has a repair mechanism, but it's not very, it doesn't happen very frequently. Whereas the CRISPR system seems to be very efficient, so that whenever this CRISPR enzyme gets into the cell, it can cut the DNA in the correct place almost all the time, which is really impressive. Sorry, my dog is whistling. Okay. The biggest challenge for delivering the DNA or the RNA is how to get it into the cell. And so there are a couple of different ways that we've tried to do this, but most of the methods, that what seems to work best is to take advantage of nature's best DNA delivery system, which is a virus. A virus is so small, it's just the DNA wrapped in some protein. And when it gets into a cell, it makes more DNA that makes more protein, and then it leaves the cell and goes and infects another cell. Well, what we do is we take the protein that covers the DNA, and we replace the virus DNA with the DNA that we want to go into the cell. So, you might think of it as a Trojan horse, but it's more like a Trojan horse full of good things instead of, attacking enemy soldiers, right? So we talk about viruses, but these are not really, they're not infectious. Like, they don't cause a disease. They don't cause, they don't replicate. They don't become more and more and more. We're just using the outside of the virus to deliver the DNA that we want. Are there any questions about that? Does that make sense to everyone? Or are there questions? Please speak up if you have any. I'm quite happy to answer them on the go.
I actually have a question here because,
Okay.
it's Christina. I wonder, now, what I don't understand is when this gene therapy, it would correct actually the gene, but now the genes have already encoded the protein. So I think I understand that the current problem of my son in this case is that the receptor is not working properly, but now it has already been encoded. So what sense does it make to correct?
Yes, that's a great question. I'm going to bring you to the next slide, and I'm going to bring you 2 slides forward. Okay, so I think the important thing to keep in mind, you're right, is that we go from the DNA to the RNA to protein. But it turns out that the cell is constantly making new protein, making new RNA, making new protein, and breaking down the old protein, because the old protein will get damaged. It will get oxidized, in the same way that, things get damaged by UV irradiation or by oxygen, or, there's just damage that happens. And so there's a constant renewal. And so, yes, you're right that, that it is, those would still be there, but eventually those would get replaced if we fixed the gene. So great question. Thank you so much for asking it.
Thank you. Makes sense.
Okay.
Thank you very much.
Okay, great. So I'll go back one slide, which is I'm going to talk about 3 different strategies. And, honestly, there are so many different ones that I don't think I could cover all of them, but these are 3 that I think are worth considering for the GRI patients. So we're talking about GRIN and GRIA and GRIC. The same would be true for any one of these. So one strategy is gene replacement. And the idea here is that you're delivering DNA or RNA to cells to replace the missing or non-functional genes. So here you would have the coding sequence that would make the correct version of the protein, and you would deliver it into the cell, and it would have all of the instructions to make that protein right there in that little piece of DNA that you've delivered. Another therapy that you may hear of is something called ASO, which stands for antisense oligonucleotides. It's a really big word, but what this means a short stretch of DNA or a short stretch of RNA. So that's the O part. And antisense means that it is pairing up with the DNA or the RNA. And so you know that every DNA sequence has kind of a complementary pair. And when we look at the helix, you look and see that there's this base pair here and it pairs up with this here. And so we know that this DNA is very sticky and RNA is the same way. And so if you have a sequence that matches perfectly, like its perfect mate, then it will stick up next to that other piece of DNA or RNA. And so we can design, if we know that this is the problematic sequence, we can design something that sticks just to the problem, and it can cause that gene to be silent, essentially. When this is sticking here, it will cause the gene to either, it can't make the RNA, or the RNA gets chewed up. And so it is going to prevent that gene from being able to make a protein. And then the last one, of course, is the Crispr, which is the gene editing. And the idea is that you have this enzyme that will scan all of the genome, and it will arrive at this one sequence. And when it finds that one specific sequence, it will cut it, and it will have a template that will then go in and repair and replace the variant that's causing the problem with the correct version. Now, this is not always precise. So the CRISPR is really good at just cutting. And that's really what nature designed it to do. It is less effective at doing this repair mechanism. And they are working on making new versions of the enzyme and new ways to do this to make sure that it properly cuts and that it properly repairs without making mistakes. I'm really sorry, my dog is crying. I just can't get him to stop. Okay, so I am showing this to remind everyone about how the Nmda receptors or the AMPA receptors or the kainate receptors are made. So I made this slide when I was talking to GRIN parents, but I recognize that some of you have GRIA or GRIC children, and it's the same thing where you have several genes that encode for the different subunits that you need to make up the receptor. The receptor isn't made of just one protein. It's actually made of an assembly of proteins. And really, there's only one of those subunits that is problematic. So in this case for GRIN, we have really just two genes that we're talking about. We need to have a GRIN1 and we need to have either a GRIN2A or a GRIN2B or a GRIN2C or D. And so if one of those twos is not working, there would be a problem. So the DNA is here, it stays in the nucleus, and this DNA endures forever. It shouldn't really change. And whenever the cell decides that it needs to make an NMDA receptor, there is machinery that will that will copy this DNA and into this RNA. So RNA is a very transient molecule. It doesn't stay around for a long time. Its main purpose is to be the template that is used to make the protein. So it's just giving the instructions in an RNA form, and then there's a machinery that will then convert this sequence into an amino acid and string them together to make the protein. And so this is the process. And then you have these subunits here, you have these subunits here, and then there's an assembly of these subunits together. And so in this assembly area of the cell, it will grab an NR2 subunit, it will grab an NR1 subunit, it will grab another NR2 subunit, it will grab another NR1 subunit, and then it says, okay, quality check, everything looks good, you can go to the surface. And so this is what our cells are doing. And NMDA receptors last about 18 hours, and then they get brought back into the cell, they get broken down into the little amino acid bits, and new ones are being brought out to the surface all the time. So I'm going to stop and ask, are there any questions about this process? Okay. All right, so now I'm going to talk about knowing now how
Ramsey?
Yes, please, go ahead.
Excuse me. Earlier, you mentioned something about oxygen when you were
Yes.
looking at this slide.
Yes.
Is there any, what are your thoughts about oxygen therapy? Is that something that's being considered, or is it not relevant, or?
Okay, right. So oxygen is one of those funny things where we absolutely need it to survive. Okay. We need it to make ATP, which is the energy that we need to run every aspect of our bodies. But in that process of making ATP, there's also something called reactive oxygen species. And these are little molecules of not two oxygens together, but maybe a single oxygen floating around looking for something to attach to. And this single molecule of oxygen is reactive, meaning it needs a partner. And so it can stick itself onto a protein. And if it does, then it can change the shape of that protein and sometimes change the function of that protein. So what I would say about oxygen is that we need the just right amount of it. Too little is bad and too much is bad. And our body has perfected getting the right amount. Now, if there is a problem with oxygen delivery, like, when people have lung infections and they need extra oxygen, then of course you need to have that extra oxygen. But if there's not a problem, then, it might actually cause a problem to give more oxygen than what the body needs. Does that make sense?
Potentially new associates and or members of that, right?
Oops, I think someone has their. Megan, can you mute? Are you able to? Okay, there you go. Okay, great. All right. So I'm going to talk first about gene replacement. Okay. And the idea here is that you're going to bring a wild type version of the affected gene into the cells of the body with a virus. And again, we have the challenges of getting that virus into the brain and also making sure that it gets into the correct cells of the brain. But assuming that we can accomplish all of those things, the virus then delivers that DNA into the cell. It does not necessarily incorporate into the DNA of the person, okay? So it can exist as a separate little entity that just makes RNA and makes protein. And if this is the case, then we don't have to worry about it causing a new mutation, because whenever you put something into DNA, there's a chance that it could go into a gene that you actually need. And so when you put this sequence in, you might cause a new problem. So having the DNA in a way that it does not integrate, that it does not become permanently part of the DNA of the person, can be a good thing. Okay, and so what we would have here is, let's say we have a person who has a variant on one of their 2 copies. That means that about half of their RNA that is made would have this misspelling, and then the other half would have the correct spelling. But if you bring in another copy, then you're going to have more copies of the correct spelling. And so the idea here is that even though, yes, you do have some misspelled variant subunit, you would have more of the good subunit. So you would have a greater chance that you would have a full receptor that is made of only good subunits and fewer of the ones that have, you know, a variant included. Kay, do you have another question? I see your hand
Yes,
up. Yes.
just wondering on the oxygen, does altitude have any impact on what might be needed? My granddaughter was born at 7,000 feet, lives at 7,000 feet. Does that have any implication around oxygen need?
You know, I have to say I'm not an expert on this. So I believe that our body, normally people are able to live at higher altitude because they make other adaptations. Now, if this gene plays a role in making red blood cells or in delivering oxygen, then maybe it does, but I don't have an answer for that. And I am really not an expert on that. So I would say it is an interesting question. It is a possibility, but I cannot confirm or deny it at this point. Does that make sense?
Yes, it does. Thank you.
Okay, okay, sure. All right. So, so this is the gene replacement. So we're not really swapping out and putting in a new gene and taking out the old one. We're just supplying the information to make the functional protein. Another strategy, the ASO, the antisense oligonucleotide. Here, again, let's imagine that we have one variant allele and one healthy allele of this gene. Now, this could be a GRIA gene, this could be a GRIC gene, it could be on one of the GRIN2 subunits. It's the same principle. But the idea is that you can design this sequence so that it only sticks to this spelling of the RNA, and it doesn't do anything to this spelling. Now, that's tricky. It takes a lot of trial and effort to find the one sequence that works. And of course, every child could have a different spelling. So you would have to get a different ASO for every, every variant. And there might be 7 or 8 people who have a certain variant, but that's only a few out of thousands of patients who have some misspelling somewhere in these very big genes. So what happens when you have this ASO in the cell is that the cell's machinery will see something that looks like double-stranded RNA. And this is also what a lot of viruses are, is double-stranded RNA. And so whenever a cell sees double-stranded RNA, it says, you're a virus and I'm going to chew you up. And so it will essentially destroy this version of the copy. And instead, all you have are the healthy versions. And so you make then the normal subunits and the normal receptors. One thing that is interesting here is that, I mentioned that RNA is really labile. It's very easy to destroy. RNA on its own, only lasts a few minutes because there's all kinds of enzymes that want to chew it up. And that's why the COVID virus, if you have that virus out in the sun, it's gone in a few minutes because it's RNA, it's not DNA, which is very stable. Okay, but these drugs that they make this ASO out of are not exactly RNA. They're somewhat like RNA, but they can't be destroyed by the enzymes. So they actually can last in the body for 3 to 6 months. And so if you have a way to deliver that RNA, then it can stay in the body for 3 to 6 months. Now, again, this is not a permanent fix, but it would be like a medicine that lasts for 3 months, and then you would need to have another treatment. Okay, are there questions about ASO? All right, I'll move on then. Okay, so you can combine these two approaches. You can have what's called knock down and replace. So you would have something that would eliminate the misspelled version of the RNA, and at the same time, you would deliver the healthy version. So here you would have, really you would replace whatever you are knocking down here. So you would make sure that you would have the correct abundance of Nmda receptors. And then finally, CRISPR. So for CRISPR to work, you need to deliver the instructions to make the CRISPR enzyme, and you need to also deliver some repair sequence, which is, again, a little oligonucleotide. And so you have, again, to somehow bring all of this equipment into the cells, and then the CRISPR enzyme will scan all of the DNA, and it is encoded to find a specific sequence. And so when you have this correct sequence identified, it will make a cut, and it will use this repair template to line up and try to replace the cut DNA with this new template. And as I mentioned before, the idea is that then you would have the correct spelling. This is done at the DNA level, so this would be a one-time thing. Once it's fixed, then that would be the only treatment that would be needed. However, there are some concerns with CRISPR because it's not very good at, it's not perfect, right? It can repair, but it can also make cuts. And so it could cut the healthy copy, or it could cut this copy and create a deletion rather than making the correct spelling. So, so those are the three, kind of strategies that are often considered for gene therapy. And, there are extra challenges for gene therapy that we don't have with drugs, which is, how do we design the medicine to go to the correct cells? So these viruses, we can put the DNA or with a virus shell, we can somewhat engineer them to go into specific types of cells, but it's not precise. So there are some viruses have what's called trophisms, which means they are attracted to certain types of cells. So they will go into blood vessel cells, or they will go into neurons, or they will go into astrocytes. But it's hard to do this 100%. And it's hard to make it match the expression pattern that you normally have with whatever gene you're interested in fixing. There's also a question of how long the benefit will last. And this is because, for things like ASO and even for the gene replacement, eventually the DNA or RNA that you've introduced will go away. And so you will have to, re-administer it. And the question is, how many times will you have to administer it? And if this is something like a drug that's given into the cerebrospinal fluid, for example, has some risks to it, because whenever you're poking a hole into the cerebrospinal fluid, you have a chance to introduce some infection. And so you just have to be cautious. And so this is one of the concerns that you need to think about with gene therapy. And the other one that I mentioned is you want to avoid damaging the DNA. And so if I go back to these other options here, this one, you're not really damaging the DNA if you have this new cargo you're delivering is kept away from the genome. But some viruses will bring this DNA in and it will insert it into a gene somewhere, not necessarily at the GRIN1 gene, but at some random location. And so with those kinds of viruses, they're called lentiviruses, then you worry that you will interrupt an important gene in the process of trying to provide the gene that you're using as your therapy. And you don't have this concern with ASOs because they don't do anything to the DNA. So that's a benefit to ASOs, is there's no risk of damaging the DNA. And then with CRISPR, there is the risk of damaging the DNA, because while it is pretty good at going to the correct sequence, it will sometimes make a cut at another sequence. And once DNA is cut, then there's a chance for some sequence to be chewed away before the enzymes come in that would repair that break. So anything that cuts DNA can cause a new mutation, and sometimes it interrupts, a space where there's no gene at all, but sometimes it causes a problem in an important gene. So those are things that we need to think about with gene therapy. And I just want to say that, even though I think ultimately other scientists besides me will figure out how to fix all of the problems with CRISPR, right now, I don't think it's the right answer for the GRI patients, because it's better at cutting than it is at repairing. So it's more likely to cut and cause a deletion than it is to repair. And, our GRI kids often will have one functional copy of the gene and one variant copy. And so what we don't want to happen is to make a cell that has one variant copy, and then we've gone and cut the functional copy, and now we have a cell that has no functional gene. CRISPR can cut other genes besides the GRIN gene, and those mutations in other genes could lead to problems. And of course, the one that we worry about is something like cancer, because if one cell doesn't work well and maybe it doesn't, make energy anymore, then it will just die. But if we cause a mutation that causes the cell to divide and grow, then we have the potential to make cancer. So those are really the mutations that we worry about. And the other thing is that for CRISPR, it's really based on the individual sequence. And so we would need to optimize for every single variant. And so that would mean it's going to need its own mouse model, its own, preclinical research, its own clinical trial. And so, this is why I'm thinking that it might be better to do something like a gene replacement strategy, or a knockdown and replace, or an ASO, something like that. But ultimately, if we can fix all those other problems, then we would have a permanent solution. So, let's all hope that the scientists who are working furiously on this come up with solutions for these problems. So I'm going to pause and ask if there are questions about that. Okay. So I wanted to stop just by saying this is what we're doing right now with the gene therapy trial that we're starting that Keith had mentioned. And we're doing this, really, Homology Medicine is giving us a lot of guidance about how to do this, because we are novices. This is our first time trying this. But the first thing that we are doing is we're doing some dose finding studies. So this is where we give different amounts of virus. This means 10 to the 13 or 10 to the 14 vector genomes. And we are going to then study the brains, the hearts, the livers, and make sure that the virus is getting into the brain in sufficient amounts, and that we don't have too much virus going into other tissues like the heart and the liver. And there are things that we can do if we do see it in those organs to reduce it in those organs and make sure that it's brain specific. But this is what we need to do. That's one of the things to test for toxicity. We're also going to then, after we find the right dose, is we're going to try different promoters. So the promoter is this little arrow here, and this is the direction that decides which cells will actually make the protein that this has the instructions for. And so we are going to try some that only will make the protein in neurons, and we will try other promoters that will make the protein in lots of different cells. And we'll see which is better for the health of the mouse. And finally, the other thing that we're going to try is different routes of administration. So intrathecal means going into the cerebrospinal fluid, like a spinal tap, but instead of pulling fluid out, we would be injecting the virus in. And then the other way is to give it into a vein with an intravenous injection. And in the mouse, the vein that we use is here in their tail. That's the one that's really easy to see. So we've started with this because if we can get intravenous to work, that would be so much safer and would be much more preferable than something like intrathecal. And, the other option that we could do is to do something into the brain itself, but we're hoping that one of these two methods would be effective. And Homology Medicine has given us, with their expertise, they think that intrathecal can work if intravenous gives us too much, for example, in the liver and in the heart and not enough in the brain. So what we'll do is we will test these viruses that will deliver either GRIN1 or GRIN2A or GRIN2B. We're going to try these in our different mouse models. So we're going to be trying them in a knockdown mouse, which would be like a model of haploid insufficiency. So this is where if you have a nonsense mutation in one copy of your gene and you just have half as much as you should have, this would be the mouse for that. We have a gain of function variant. We have some loss of function variants. And we're making a GRIN2B mouse that would be a loss of function variant. So we'll take these, we'll treat them with the viruses, and then we will test them for lots of different behaviors and see whether they get better. Then we'll take their tissues and measure, did we get more protein expression? Did we fix the receptor? And we want to make sure that there's no toxicity. Sorry, my throat's dry. Okay, I think this is the end. I'll stop here and take any questions that you have. And I'm going to go get a drink of water really quickly. Sorry.
Thanks, Dr. Ramsey.
My pleasure. Sorry about that. I should have had some water standing nearby.
Do you have any questions?
Can I ask a question, please? So you got 5 or 6 mice, it sounds like. Would it be helpful to have a broader range of them, or would that be a benefit to your research? Or
so yes, I mean, the main issue is just that the mice are very expensive to maintain. And so the more different models you have, the more expensive it is. But
Sure.
The answer is, I think, yes, unfortunately, because we're finding as we study these different variants that they're each different, just like your kids are each different. And so I think it would be good to try them on as many models as we can. But I think that with the strategy we're using, if it works for one loss of function, it should work for other loss of functions.
okay, thank you.
Sorry about that. Yes, Susan, do you have a question? I can't hear you. I don't know if anyone else can hear you, if it's just me. Maybe it would be good to put it in the chat. If
While we're waiting on Sue to ask her question, does anybody else have any questions?
Yes, I have another question. I wanted to ask, so in principle, when the proteins are getting renewed, I don't know, or the receptors every, I don't know, 18 hours or something, I
yes,
think you
every
said.
day or 2
So-
days, yes.
So that would in principle mean that a treatment would then be successful no matter how old the patient actually is.
Right. So this is the really big question. Yes, in one sense, you're right, that the treatment should work if your child had a disease where they were missing an enzyme to, let's say, an enzyme to make some important thing. I don't know. I can't think of something. Then you would start to get benefit right away. The problem with neurodevelopmental disorders, is that a lot is going on when the brain is connecting together. And we are not sure how much we can fix problems after everything is all connected. So, you know, it's like if you think about your brain like those little chips in your computer, you know, that are all wired together. And if there was a bad connection, how hard it would be to then, you know, reroute and make it go in a different way. And so this is an ongoing question. And the encouraging thing is that when we used the knockdown mouse and we did kind of a gene therapy type of experiment in the mice, we actually did improve a lot of the phenotypes, which is like symptoms for a mouse. We did improve a lot of the phenotypes, but not all of them. So I think that it's important to know that it would be unlikely to fix everything completely. But I think it is likely to dramatically improve the health of the child. I think that that is likely. And, you know, the NMDA receptors, the AMPA receptors, and the kainate receptors are all different. So they might have different abilities to recover. So we really need to do the studies for each one of these, you know, types of receptors. And we're just starting that work. So I would say that we still don't know a lot about how much we can expect to reverse the symptoms, but I'm pretty hopeful, actually. So, and this is based on the research that we have done and published in 2020. So I didn't prepare that. I wanted to just talk about gene therapy, but I do want to reassure you that I think that substantial improvements are possible, but probably a complete 100% improvement to, you know, completely neurotypical is hard for me to imagine. I wasn't able to achieve it in my mice. That's what I'll say.
Thank you very much. Very useful. Thank you.
Okay.
I see that Sue's question got put in the chat. So how long do the trials last? So I'm assuming that's probably for your mice studies. Right. Okay, great. Well, I think that a year would be an appropriate amount of time. So to track any one patient, they would probably, now I'm not going to design that clinical trial, but, you know, Dr. Benke talked about how it's important to track them for a long time. And I believe that that was looking at a 52-week period of time. Now, the trials don't start all at once and everyone is enrolled and starts the same day. So usually these trials would go on for 2 or 3 years while patients are getting enrolled and, you know, they're following along. And then if it looks like it's causing a problem, they can stop a trial, you know, as soon as they see a problem. But if it's looking good, they still can't report it until everyone is done. So you know, even once the trial starts, it's probably another 3 years before they have an answer about whether it's effective or not. Okay. All right.
My pleasure.
Do we have any other questions?